Kia ora koutou and welcome to our digital event. It's great to have everyone joining us tonight. I want to start with a quote that I have hanging on my wall at work, which really talks about the power of research. Aharu taku toa, iti toa takatahi engari, hi toa takatini. My strength is not as an individual, but as a collective. As you can see, your camera and microphone have been automatically turned off and you will be unable to turn these on. This means we cannot see or hear you. Instead, we invite you to use the Zoom chat and Q&A functions to communicate with us during the session. You'll find these functions at the bottom of your screen. We would like to express our gratitude to everyone who submitted their questions during registration. We will try to answer as many as we can, but bear in mind we do have limited time. Later on, if you have a question, please keep all the questions related to the topic presented, and our speaker will not be able to answer any personal medical related questions you may have. At the conclusion of the session, we will end the Zoom for everyone. The recording will be available on our lecture library at a later date. So now it gives me great pleasure to introduce our speaker tonight. Welcome, Alice. So Professor Alice Theodem is a registered psychologist and Professor of Psychology and Brain Health at Auckland University of Technology. She's the Director of the Traumatic Brain Injury Network, a recipient of the Rutherford Discovery Fellowship in 2019 and an AUT Research Excellence Award in 2024. She's recently become the co-lead of the Women's Health and Neuroscience Research Program, and I was very grateful to be invited along to the launch of that this year, which is a really exciting program. So welcome, Alice. You can come and join us now. Thank you so much for joining us tonight.
Thank you, Sarah. Appreciate the introduction.
Really looking forward to the topic, and you can share your slides now and go for it.
Thank you. Hopefully they should be coming through now.
They just need to be in slideshow mode. That's perfect.
Fantastic. Thank you. Tēnā koutou ngā mihi nui kia koutou katoa. Hi everyone, I'm Alice Theodem, a professor of Professor of Brain Health at AUT, and I just wanted to thank you all for joining me this evening, and huge thank you to the Neurological Foundation for hosting the event and for inviting me along. I really appreciate that. And I guess before I start talking about the work I've been involved in over the last 15 years, I just really want to thank the thousands of participants and their whānau who have taken part in our studies. It really wouldn't be possible to do this work without you sharing your experiences and contributing your time and enthusiasm to our work. So really to acknowledge all the effort that people have given us over the years with the work that I'll be sharing with you. And also just to acknowledge and particularly to reflect the whakatauki that you kindly shared with us, Sarah, in that none of this work has been done on my own. I've had a huge team of colleagues around me and also a lot of supporters out there in the community and funders who've supported this work. So a huge thanks to everyone who has contributed along the way. Now, just to share a little bit about myself, just to give you an idea where I'm coming from and what really motivates me with the work that I'll share with you this evening. I'm originally from the UK, in a small town in the southeast of the country called Malden, which is just tucked in the little estuary down the bottom there with the red mark. And one of the things I always love when I go to New Zealand supermarkets is to see a little bit of my hometown. Some of you may be familiar with Malden sea salt. And that's processed on the little Blackwater estuary just marked on the map there. So really nice to see that over here in New Zealand, given it's a very small little town in the southeast of England. Now, before I came to New Zealand in 2009, I actually trained and worked as a health psychologist in the UK in their national health system. And so, having worked as a clinician, that really is a driver for me in the work that I do. I'm really driven to do research that actually can translate into everyday practice, both to improve outcomes for patients and their whānau, but also to assist clinicians in the work that they do as well. And I guess I also have to confess I have a personal interest in this work. As you can see here, this is me and my horse. I've been involved in equestrian sport since I was 11 years old, and it's a big part of my life. And so I very much have a personal interest in this field as well as a professional one, as well as my own experience of concussion over the years as well. So before I go on any further, I think it's always important to really sort of clarify what I'm talking about when I'm talking about a traumatic brain injury or a concussion. And what we mean by these injuries is an injury that's caused by an external force to the head or the body. So this isn't talking about those internal injuries like a stroke or strangulation where there's a restriction of oxygen to the brain. And this is where there's an injury caused by an external force. And that leads to what we call an alteration of consciousness. So what that might look like is someone being knocked out, they lose consciousness. It may be that they report feeling dazed or confused. People often describe it as feeling like they're seeing stars or they're feeling really dizzy or disorientated. And a key sign is people not remembering what's happened and asking repetitive questions about what's just happened to them. And so one of the things we often talk about, particularly when I talk about the term concussion, the first thing that seems to spring to mind is around sport. And sport is a cause of concussion and traumatic brain injury, but actually most injuries aren't caused through sport. Most injuries tend to be caused by those everyday slips, trips, and falls that we're at risk of. It can also happen by people hitting their head against an object or an object hitting their head. It can be caused from a blast. It can also be caused through a vehicle accident or an assault. So there's many different mechanisms that can cause these injuries. And so it's important that we really look at the whole spectrum of these injuries. Now, one of the hardest things I hear from people is really understanding what has happened to them when they've sustained one of these injuries. And so what we've done is tried to develop this image for you so that you can see what's happening inside your brain. So this is what we can't see. So our jelly-like brains are quite fragile, and they sit in a fluid within the hard skull. And the hard skull is there designed to protect the head and the brain from those everyday movements that we can experience. But when there's a significant force to the head or to the body, the brain gets shaken inside the hard skull and actually bumps against it, and the tissue can move against some of the jaggedy surfaces inside the skull. And as you can see here, the brain tissue actually contorts and stretches. The brain doesn't move as one fixed tissue. It actually moves around quite a lot. And this is why we see a lot of complex symptoms happening, because lots of different areas of the brain can be affected because of the nature of what's happening to it. Now, if we look at this at a more micro level, what's then involved is that the brain is made up of billions of neurons, which are connected by axons. And these axons are like tiny fibers that enable the brain to communicate messages across different areas. So as that brain is contorting and becomes stretched, these fragile axons can become damaged and torn. And this is what makes it really hard for the brain to do even simple tasks. Now, one of my colleagues, Josh Faulkner, often likens this to driving down a road. So normally you can drive from one end of the road to the other relatively easily. But if there's potholes in the middle of that road, the journey becomes much longer and much harder. And that's what's happening to the brain, is these neural pathways have their own potholes, and then the journey to communicate messages across different areas of the brain becomes harder and longer. In addition, there's a whole array of other things that are happening. So there can be a disruption of neurochemicals. There may be some inflammation in the brain, a bit like when you strain an ankle, you can get inflammation. In more severe injuries, you may also get a brain bleed or a skull fracture. So lots of things are actually happening inside our head when we're talking about these injuries. People often describe as head knocks. There's actually an awful lot that's going on inside our brain. First of all, just to be really clear, when I'm talking about concussion, I am talking about a mild traumatic brain injury. It's a term that's mainly used in the sports context, but it's also a term that I understand the public's more familiar with. But it is actually referring to a mild traumatic brain injury. There's international consensus now that they are the same thing. And we used to think of these injuries in terms of mild, moderate, and severe in severity. But there's now an international move away from these labels because they're not found to be really clinically useful. There's people who can have a mild brain injury and actually have quite significant problems as a result of that. And there can be people with a severe injury who actually recover their functioning really well. And so the terms don't necessarily have much meaning in terms of what the injury means for a person. And so the way I tend to think of it is like a spectrum, and there's no clear-cut boundaries between the different labels. There's a lot of grey space between them, but I think of it as a severity spectrum. And we've also got these subconcussive injuries, which is where there's a head knock or repeated head knock that the person may not have any symptoms from, but it can be linked to longer term brain health. And so that's where I sort of really think about this full spectrum of injuries. But I'll mainly be talking about the mild TBI and concussion this evening. So we talked about earlier that this isn't just an issue for sport. So who is at risk? Well, unfortunately, all of us are. And a study back in 2008 by Audrey McKinley showed that 1 in 3 people will have had at least one of these injuries before they're 25 years old. And so it's something that we do all need to be aware of. If it's not happening to us, it may be very likely to be happening to someone close to us. So this has been the real focus of my work in determining how these injuries affect our wider communities and how we can improve diagnosis, treatment, and recovery for people who have been affected by them. Now, the other reason we need to get better at managing these injuries is that, as you can see from this graph, which is from an analysis that my colleague Doug King has recently done, that's due to be published shortly, is that the number of brain injuries in New Zealand is increasing, and it's increasing faster than our population growth. And so this may be a trend that, with the increased awareness now of concussion that we've seen over the last 10 years, that people may be more likely to be reporting these injuries. But it's also indicative that these injuries are not decreasing. And we would be hoping that would be the case with increased awareness, that there would be more prevention and less of these injuries occurring as well. Now, it's interesting, you can see there a little bit of a dip in 2020, and many of you may remember that was the year of COVID. And so it was a really interesting period where actually the injuries that we saw were from a very different range of mechanisms. So we saw less of the sports-related injuries and more of the accidents in the home, and unfortunately a sort of increase in domestic violence during that time. Now, the early work that really got me interested in this space was from a study where we were looking at how many people in New Zealand were experiencing a brain injury, and we were following up these people for a year, and we were tending to focus more on the moderate and severe injuries back 15 years ago now. But what really struck me was what participants who had had these mild traumatic brain injuries and the stories they were telling us just didn't match. We were expecting them 15 years ago to recover relatively quickly, but what we were hearing was not the case at all. And that's what's really driven the whole program of work that I've been involved in ever since. Because what these people were telling us, so we used to think these people would recover within a couple of days or weeks of the injury, but actually at 1 year, nearly half of our sample had 4 or more symptoms that were disrupting their everyday life. So these symptoms weren't just an inconvenience, they were actually really impacting people's ability to function. And there was a wide range of symptoms that people were reporting. So, around a third of people had headaches, they were feeling more irritable, they were experiencing dizziness, which we tended to think is very much of an acute symptom back then. A lot of people were struggling with cognitive tasks, so finding it harder to remember things, but also harder to process new information. A lot of people were reporting that they had more fatigue than usual. But also people were reporting that they were more sensitive to noise, and activities such as going to a cafe with their friends was becoming really stressful because of all of the information that the brain was having to process when they were in an environment like that. And one of the things that we then saw as we followed people up, or continued to follow them up, because we thought this cohort was telling us something really interesting, is that the cognitive symptoms were the ones that really persisted in the longer term. And it's been interesting in following these people up. So we followed them up at 4 years, at 8 years, and at 10 years recently to see how they were doing. And it was quite interesting that even 4 years after injury, a lot of people were saying that they had actually left their employment or reduced their working hours because of their injury. So about 17% reported that they had reduced their hours or left work, and this was for other reasons than retirement or taking study, for example, that would be positive reasons to leave. And so that for us was really striking and really highlighted the impact of these injuries on people. We were also seeing that there was a significant or lower engagement in the community. So, like I described, people finding cafes really difficult to go out and meet their friends socially, or to go to a supermarket was extremely challenging because of the real environmental stimuli that goes on with the noise and the lights and all the different products within the supermarket environment. We were also hearing at this stage the number of social relationships had actually become very strained. People were expecting their person or their loved one to feel better by this point, and they didn't understand why they were still struggling, and that created a lot of tension for these people. We also realised that there was an increased risk of re-injury. So even within the first year after they'd had an initial injury, around 10% of our sample actually went on to experience another mild brain injury or a concussion in the general population. And this was much higher than we expected, but maybe linked to people's reduced balance or visual perception. And a lot of the injuries were actually sustained during the same activities as the initial injury. So there is a real opportunity for prevention here. And some of you more recently may have seen some of my work. We've been looking at the impacts on longer term behaviour, particularly in terms of criminal and antisocial behaviour. And unfortunately, we are seeing an increased risk of engagement with antisocial behaviours later in life as a result of these mild traumatic brain injuries. So they really are something that we need to be taking quite seriously. Now, whilst I've highlighted quite a scary picture of what can happen after these injuries, I do want to provide some reassurance that actually we're talking about half of the sample here, and half the sample did actually recover very well from these injuries without any treatment. And this sample is a sample from back in 2010, where actually very few people actually received treatment. And so this for me is a real opportunity that we have here to reduce these longer term impacts that we're seeing. And I would hope now with the advances that we've made here in New Zealand, that the prevalence of those longer term problems will be much less as a result. Now, one of the things we're hearing more and more of, and some of you may have also listened to Helen Murray's talk earlier in this series, where we're thinking about the long-term impacts from injuries such as concussion. And the injuries I'm talking about are the injuries that we see in the general population. And these longer-term health impacts from concussion are really about people exposed to repetitive head injuries. So a period where the brain has a lot of these impacts in quick succession before it's had time to recover. And so they're the group of people that we have linked to the potential increased risk for neurodegenerative conditions like dementia and the chronic traumatic encephalopathy that Helen was talking about. So just to be, just wanted to play or really communicate some clarity around that. And one of the studies that we undertook to really check this was to look at a general population sample. And many of you may be aware of the incredible Dunedin study that we're so honoured to have here in New Zealand. It's telling us so much information. And we partnered with them to have a look at their cohort's history of brain injuries. So many of you may know that there's about 800 people in their sample that have been followed up since birth. And so we were able to look at their medical records and their accident records across their lifetimes. And I was able to go through every person's concussion history. And then we were able to link that to cognitive functioning at age 45 years. And you'll be pleased to hear that actually the injuries that we're seeing in the general population are not linked to early cognitive deficits in mid-adulthood. So there doesn't seem to be any link in the general population between these injuries and early cognitive decline. However, repetitive injuries aren't just an issue for sport either. So we often talk about these repetitive injuries in sports such as rugby, but actually they're also an issue for people who experience repetitive injuries through other causes. So for example, domestic violence, and most of the injuries experienced there are to the head or to the neck. During an episode, people may be strangled, so they may have an acquired brain injury, as well as being punched in the head. They may fall over and hit their head on the wall. And so there's multiple impacts that can happen within a single event. Now, unfortunately, this is a very underserved group, and a study by my colleague Doug King also showed that very few of these people are actually being picked up, identified and referred to concussion services, even though that we know that there's a link. And so that's something we really need to improve on here in New Zealand. Also, we've recently been working with people in prison, and one of my students, Tracy Mitchell, did her PhD looking at the prevalence of brain injuries of men in prison, and she found that a very high prevalence, that 64% of the men in prison had sustained at least one significant injury. And what was most concerning was that 1 in 5 of these were very early in childhood. And a number of them had significant periods of multiple injuries sustained over their lives. There's also a very high prevalence of people who are homeless or marginally housed, with this study recently published that showed that around 1 in 4 of them had experienced a moderate to severe injury. So we have lots of vulnerable groups that are really affected by these injuries that need much more attention. We're learning a lot from sport, but we really do need to also focus on these other at-risk groups. Now, one of the questions I get asked all the time, and I wish I knew the answer to, was, well, how many then is too many injuries? And it's really interesting when you look through the research, the number of TBIs isn't really a good predictor at all. There were some people talked around, 3 or 4 isn't good, but actually it doesn't seem to be a linear relationship at all. It seems to be much more complex. Yes, number of TBIs is a factor, but what seems to be more important is how long there has been between the different injuries. Had the brain fully recovered before the next injury was sustained? How serious the previous injuries were? And also what help people got. If they've got treatment, they know what to do, they were recovering quickly, that can also have an impact. But one of the things we are seeing, which seems to be an important indicator for people to look out for, is if they've had a previous prolonged recovery. And what I mean by that is if it's taken them a few months to recover from an injury before, that's the brain really trying to tell you that it needs more time to recover and that it's feeling vulnerable and probably at risk if you have another injury. So that's something that we can look out for. And if we are starting to experience prolonged recovery from these injuries, we might want to really think about protecting our brain as much as we can. Now, this is one of the things our team are currently really focusing on in terms of how do we collect all of this information about people's histories so we can then create tools that give us a much more advanced understanding about what's happened to someone over their lifetime and what their level of exposure and risk might be, because that's something that I think a lot of people would really appreciate knowing the answer to, particularly myself. Now, over the years, we've heard that having these injuries for those who don't recover well can be incredibly complex. And there's a lot that people are having to process and deal with after they have these injuries. It's very hard for people to find accurate information. There's a lot of uncertainty. No one can tell you when you'll be recovered by. And a lot of people don't know what's out there. They don't know that we have concussion services here in New Zealand, that actually there is something that GP and ED doctors can do. And they don't see what's happened because it's an invisible injury. And so not understanding what's happened to their brain it makes it really hard for them to understand why they're really struggling with quite simple things. And whilst they're going through this process and they're trying to give their brain time to recover, actually life keeps moving, and it's really hard for them to feel like they're trying to keep up with life whilst also trying to manage what their brain needs and to try and rest and give it time to recover. And so it's a really challenging process. And one of the hardest things people talk to us about was that actually navigating our healthcare system was one of the most complex parts of their recovery journey. Good news, however, over the years that we've identified a number of risk factors for poor recovery after a concussion or a mild brain injury. And these are risk factors that we've found here in New Zealand that have also been found in studies overseas in the States and Europe, where if someone has a lot of symptoms that are quite severe immediately after the injury, that's one of the strongest indicators of that person needing more time to recover later on. We also know if the event was psychologically traumatic. So by that, I mean if someone was assaulted or if there was a fatality in a car crash, those psychological impacts can make the recovery journey much more challenging as well. We do know that there's a cumulative effect, or the impact of a serial number of concussions can have an impact. So if people have had lots of previous injuries, that's a risk factor. But also this notion of having a previously prolonged recovery before is very much a risk factor for recovery from a subsequent injury. We also know that if people have come to the injury with mental health difficulties or a history of migraine, there are also factors that make someone's recovery journey more difficult, and that the impact of the injury can have a real influence on someone's recovery as well. So, for example, they may have only a few symptoms, but actually those symptoms are quite severe. So if you think, for example, if someone's a builder and they're experiencing dizziness and noise sensitivity, actually the impact of those symptoms on their ability to do their job is quite significant. And so that can have a real bearing on that person's recovery, because they often try and push themselves back to work too soon before the brain is ready, and that can then make it more difficult for the brain to recover. And interestingly, there seems to be this particular cluster of symptoms which seems to indicate the brain needs more help to recover. And these are what we call the vestibular ocular symptoms. So things like vision differences, blurred vision, double vision, but also things like balance or feeling dizzy. And so we often find that people sometimes need physiotherapy to help their system to adjust, particularly if there's also been a neck injury alongside, because until this has been reset, it's quite hard for the brain to then recover as well. So it's a particular symptom cluster that we're also noticing that has an impact. So based on this, one of my PhD students actually looked at what was happening as people travel through our healthcare system. And it's really interesting that it was no wonder it was coming through that the healthcare system was difficult to navigate, because there's so many different ways through it. People were presenting to different professionals, anything from a dentist for a broken tooth who was picking up the concussion, to an ED, to a general practitioner, to a physio, to a prison healthcare team. to a school nurse. There's lots of different entry points. Sometimes people know to report a concussion, sometimes people don't, and so they can be missed at that early point. But then there's this whole transfer of people between professionals, and that's where people were often getting lost in the system. And then it wasn't until people were really struggling, that they maybe had that initial appointment, they were then having to push to get back in to get help if they weren't recovering well. So it was a real difficult system for people to navigate. But the good thing is that we know that our system is providing the right supports to people if we can get them through. So we know if people are doing the right thing to give their brain the right environment to enable it to repair itself. Good advice and knowing what to do is really important for people. We know that if we get people to our concussion services quickly, we know they're effective. There have been meta-analyses of different interdisciplinary services that show how effective they are. But if there's a delay, then people are often in a really bad point before they get to these services because their symptoms have increased. They don't know why. There's a lot of stress and trauma, a lot of frustration and anger by this point as well. And so early treatment has been very much linked to early recovery. And so what we've been working on over the last 5 or 6 years is to develop a tool to implement those risk factors that I had highlighted to you earlier, to operationalize this for clinicians. And so we actually developed a working group of clinicians across the healthcare sector, from the emergency department to primary care, included allied health, our concussion services, people from different cultures and academics, to develop a tool that we could implement into practice. And we tried to make it as quick and easy. There should be no need for training for this to be something that clinicians would find useful. And we also wanted to make it a tool that people were able to accurately respond to. So a lot of the tools that we used before, we were asking people about nausea and amnesia, and they're not terms that everyone's familiar with. And so we've tried to make the language of these tools as simple as possible. And then what we've been working on is trying to integrate these tools into clinician systems. So our initial clinician feedback was, well, it's got to be integrated if you want me to use it. It's got to be quick and it's got to be easy. And so we've spent a lot of time working with industry such as Manage My Health and with Smudge to develop and digitalize the BIS tool, the brain injury screening tool that we called it in the end, to embed it, and we've now got it available within the medtech systems for primary care, for GPs and nurse practitioners, but also through Smudge with the Wayfind TBI tool. It's now been made available for ED clinicians as well. And what the tool does is it explores those risk factors and then highlights to a clinician if that person is at risk of poor recovery or whether they're actually likely to recover well with follow-up primary care. And of course, we make it very clear this is not a diagnostic tool and that the final decision should always rest with the clinician, because there's lots of factors that need to be explored when we're making that final decision. But clinicians have told us that they've found this incredibly useful if concussion is the primary injury. And it's also the symptom scale and impact item can be done at follow-up, so people can actually monitor how they're doing from their first presentation over the course of their recovery journey, because this is also now a tool that's being used in concussion services, so they can track how they're doing over time. And we've been working with ACC over this period to implement this within primary care, and as part of a supported concussion pathway, and we've more than 1,000 patients have now gone through this new pathway. And we were so thrilled to see that what we were seeing before were really long delays to getting to concussion services. It was taking people nearly 3 months before they got there, and they were in a really difficult place at that time. We've now reduced that through use of this tool to 20 days. So we really are highlighting those people who need help early and getting them referred much earlier too. So we're hoping that this is really improving their recovery. The other thing is that we've improved the referral rate for Māori and Pacific. So whilst Māori and Pacific have higher experiences of these injuries through engagement in sports such as rugby, for example, they weren't necessarily being referred to services at the rates that we would be expecting. And so through use of this tool, a standardised approach, we've now got a referral profile that reflects the incidence of injuries. And it's not just a case that they're being referred and not going. As you can see here, the percentage of people who are actually accessing the concussion service after they've been referred is higher for Māori and Pacific. So based on the success within primary care, we've now, as I mentioned, implemented this within the emergency department. We're rolling this out in 5 hospitals across New Zealand, and it's something that clinicians can use on their mobile device as well as a desktop computer. So we've tried to keep it as usable as possible. It's integrated into the My Health Workforce Te Aotearoa platform, so it links to the patient medical record, which is really time-saving for clinicians. And we know our EDs are really struggling at the moment, so we've tried to make this as easy as possible as we can for them. And then to kind of try and get over the problems that people were having with making a referral, finding the right form, emailing it to the place, making sure it gets there. And we've now created this direct referral to a concussion clinic to try and speed things up. So pretty much mirroring what we've done in primary care, but also wrapping it around with the other assessments that are done in the ED, such as whether someone needs a CT scan or other clinical tests that are done within the ED where more severe injuries tend to go, and so there needs to be a more comprehensive process. So that's what we're doing now to try and improve recovery from these injuries. We're also really excited that AUT is now hosting a new we call it the blood detective machine, but what that's enabling us to do is to see whether we can actually look for markers in the blood after people have had these injuries. So I mentioned earlier that one of the things that can happen is there are neurochemical changes in the brain. Well, one of the things that we're starting to see is that there's a release of proteins from the brain. So these proteins should be in the brain, but they're actually crossing the blood barrier and going into our blood. So Beth, who we're working with from Abbott on these studies, often likens it to a piñata, that, you know, when there's an impact to the piñata, the sweeties fall out. Well, a similar thing is happening in the brain, that when there's a hit to the head, these proteins come into the blood, and we can actually measure them with a blood test and with this sophisticated analysis machine that can process people's bloods and detect the levels of these proteins. Now, we know that this test is showing a lot of good evidence in the first 24 hours after an injury. What we're looking at, because we know most people actually don't go to a GP or the ED on the day of the injury. They often, you know, have the injury on a Saturday and then maybe they go to their GP on the Monday. So for this to be something that we can use on an everyday basis as part of clinical practice, we want to see is whether we see these blood markers following concussion at different time points following an injury, and to see how the levels of these proteins in the blood change over time, to see whether it's a better marker of what's going on in our brain than necessarily what we describe. So what we have got some initial evidence that suggests that the symptoms actually go away. The symptoms that we notice go away quicker than our brain is recovering. And so if we have these subjective markers, it might really help us to then provide advice to people to say, you know, your blood markers have returned to normal now. If you're feeling okay, we can look to return you to play. And so this will be really, really helpful in clinical decision making going forward. The other great exciting thing with this is that we know that women can often have a more difficult concussion recovery journey than men. Now, there's a lot of potential reasons for this, and this is why we're particularly studying women, because they often have been missed through a lot of the research. But also there's a hypothesis that hormones may also be playing a role in people's concussion recovery. And so this machine will also enable us to look at people's women's hormone levels to see which hormones are having an effect on concussion recovery, or if they even are, just to help us to understand what's going on more for women. Now, the other thing that we're really keen to do is to make sure that people have good information, because as we saw in that evidence, if people know the best environment to allow their brain to recover, that's really helpful for their recovery. And so if people haven't seen it yet, we worked with ACC to develop their concussion recovery advice. And so from before, we were just sort of giving people things to look out for if they needed to go back to hospital. We've now made it much more proactive in terms of the things to look out for if you do need to go back, but also what can you do? Because the advice has shifted a lot over the last few years. We used to think before that you had to, really protect your brain. We had, sit in a dark room and don't do anything that makes your symptoms worse. We actually know now that's counterproductive. What we need to be doing is finding the right balance of challenging your brain, but giving it time to recharge. And so there's advice to think about the activities that are more restful for your brain. So often when we think about resting, we think about putting our ankle up, if we've sprayed our ankle, and watching TV. Now, watching TV or using the screens or playing video games is actually like running a marathon on your sprained ankle. It's really challenging for your brain because you're having to process all the audio, watch the videos, follow the storyline, and you may be chatting to someone next to you at the same time, and so your brain's having to process a lot of information. So it's not a particularly restful activity. Whereas going for a short walk, for example, doing things around the house, they're activities that really enable your brain to just reset and spend a little bit more time and energy on recovering. And so we encourage people to do activities at a level that just nudges their brain into the symptoms. You've got to challenge it to tell so it knows which roads it needs to fix. But not going too far so that you then feel exhausted and you have to rest for the rest of the day. And that's where concussion services are really helpful in helping you to identify the activities that can be triggering for your symptoms, helping you find your level where your brain is able to function in those activities quite well. So that might be 5 minutes, it might be 10, it might be half an hour. And then helping you plan for just gradually increasing the time that you do those activities. Just like you would if you were training to run a marathon, you're just retraining your brain to gradually keep increasing the amount that it does at a level that it can cope with to get you back to normal functioning as quickly as possible. So I encourage you to refer to that information sheet if you haven't seen it. Now, we do have some wonderful organisations here in New Zealand if you want more help and advice. The Neurological Foundation is a great source of events like this where you can find out more, but also in signposting you to the other places that may be helpful for you. So we have organisations such as Headway here in Auckland who offer a lot of support and advice and advocacy and education. There's also the Brain Injury Association network across New Zealand that have some very active hubs across the country. Our TBI network is always a place we'll always be very happy to signpost you if we can't help you ourselves. And then if people aren't aware, there's also an organisation called Wayfinders. So if people need help navigating the ACC system, if they're trying to argue a claim or find out how to progress something, they are a really, really great resource in helping you to make your best case to ACC, helping you understand the different processes. And so I really encourage people to go there if they are having difficulties with ACC. Now, the great news is I was involved very recently in developing some guidelines to support clinicians to manage these mild TBIs or concussions much better. A lot's changed over the last 15 years and even in the last few years. And so these guidelines will be coming out very, very soon. And it should really help shift the advice and support that we're giving to people to ensure our clinicians are up to date. So we'll certainly be releasing those through the network, and I'll certainly be letting the Neurological Foundation know when they come out as well, so they can share them with you. So I've mentioned the TBI network a few times in this presentation, but just to give you an idea what it is really the idea was to connect researchers, clinicians, policymakers, and the general public to undertake the research that matters. And whilst it's hosted by AUT, our aim really is to try and break down the institutional barriers that can often occur when we're competing with each other for funding. We want to work in a really collaborative way. We want to learn from each other. We want to encourage researchers to share their thinking, their results, to help us to develop the work and help us to make advances and discoveries much quicker. And so We've got our membership's huge. We've now got more than 400 people, and we've got members of the public, we've got clinicians, people from all walks of life who've got an interest in really helping us to advance research into this space to really try and make the difference. And they help us design research studies that are really going to have the biggest impact for the public. So our research is very community driven. Rather than necessarily ideas that we've come up with, we think will be helpful. So we're really trying to answer the questions that the community want answers to. And there's lots of opportunities. If you want to sign up, anyone can become one of our global members. So if you're interested, please do get in touch and we'll add you to our database. We often share about new research that's coming up, opportunities to get involved, any updates about completed research, and also the number of community events that we hold to get people involved and really have this community-focused research network to enable us to advance where we go. So I'll leave it there because I know there's often a lot of questions, and so very keen to hear your thoughts and to provide more information where I can, but really just to end by thanking all of the people who have funded and supported our work. Without that, this really wouldn't be possible. So thank you very much, Ngā mihi.
Thanks so much, Alice. You can unshare your slides now and we'll have a look at what questions we've got waiting for us. But I think it's really great to see the model that you've got in the Brain Injury Network, where you're doing excellent research, but you're really getting it out into the public space and also into the hospitals and the clinics. So that's really exciting to see.
Just realised it's still sharing.
Okay. Our first question: can the effects of a brain injury stay hidden for years and appear much later?
It's a really interesting question. What we tend to see is that whilst the symptoms may not happen immediately, people often find that they go home and it's not until the next morning that they really start to see the impacts. It may be that they happen a few hours later, but we tend to see it within the first 48 hours of the injury. And so it's unusual for them to come out at a much later date following that. But yeah, there can be an initial delay, but not usually more than a few days.
So if somebody has a mild traumatic brain injury, they would expect to have symptoms pretty much immediately in the first couple of days.
Yeah. As I said, when we're talking about the repetitive injuries, that's a little bit different. But for just the injuries we experience in the general population, yeah, usually just in the first 48 hours.
Another interesting question: could homelessness be caused by TBI? Or TBI caused by homelessness?
Really interesting question, and something I'm really keen to explore. We are actually starting to make some links with some community organisations who are working in that space to try and explore this more. The work we're seeing in the prisons is that often there's a very complex combination of factors that leads to someone becoming involved in criminal behaviour and going to prison. I would imagine, but we need to do more in this area, there would be a similar complexity. Now, it's likely that it could have an influence on people's behaviour, but also people's behaviour can also increase risk of these injuries as well. So we know that, unfortunately, people who are homeless or marginally housed are at increased risk of assault. So it's really hard to unpack what causes what, and particularly when there's a lot of factors that are probably all intertwining that are affecting someone's life.
Yeah, I guess it sounds like it might become a bit more of a cycle than a cause and effect.
And lots of different things affecting each other too. So yeah, very complex, but certainly something we really want to look much more into.
So how does the research that's going on in New Zealand compare to what's been done overseas?
Well, I'm incredibly proud of New Zealand. We are really punching above our weight in this space. There's a number of amazing researchers here who are really having a global impact. And when we had Beth over from Abbott, who gave a talk at our launch, one of the things she mentioned is the world is watching New Zealand. And because of our because we have a smaller population, it's often easier for us to ask them the more complex questions. And so we're able to do research here in New Zealand that isn't necessarily possible in more complex systems like the United States, where they have a different healthcare system, where there's litigation and a lot of other complicating factors. So here in New Zealand, we really are, yeah, doing more than will be expected for a country of 5 billion people.
So with the smaller nature of New Zealand and the public healthcare system, do you think it's been a bit easier to implement changes in your brain injury screening tool into the clinic?
Yeah, so because, and particularly working with ACC, and that's really been fundamental to enabling this to be implemented. There is a lot of diversity between different emergency departments and how different practitioners work in primary care. So there is still a lot of diversity that we're having to work with and enabling this to be used as flexibly as we can. But there's not the complexities of someone having private health insurance. You know, they don't have national networks of concussion services in other countries. You know, that's something really unique to New Zealand. You know, other countries are very jealous of our concussion services because people can access them for free. And so that really does enable us to test things here in New Zealand in a way that's equitable, and we can see if things are making a difference because we've got populations that we can study that are representative of the general population. So we're not necessarily just looking at people who have private health insurance or, you know, a link to a particular organisation that provides a service.
Yeah. Another interesting question, is there evidence that strong social or whānau support helps people recover better from TBIs?
Absolutely, yes. You know, people talk to us a lot about how even a single person can be the big thing in their recovery journey. And that person can be a professional, it could be a friend, it could be anyone. But having someone alongside you when you're recovering from these injuries, helping you to understand your own triggers, you know, picking up when you're starting to look tired, you know, they might be able to see it before you notice it. But also just being that support and that reassurance that you're going to get through this journey. And I guess that would be, you know, one of my key messages from today is most people recover well. We need to support those who aren't recovering naturally better. But actually, even many years after these injuries, we see the brain is incredible at its ability to repair and heal itself. And so even if you are a few years down the line, please don't give up hope. The brain's amazing. You can still recover and make improvements. So please don't lose hope.
Yeah, I really like it how you compared it to a sprained ankle. That's really easy to understand what we can do with a sprained ankle, and we can actually feel how mobile it is and feel if it's still sore and that sort of thing, which we can't do with the brain. But just to think that sometimes the brain needs as much time and special treatment to get the full movement and flexibility back like a sprained ankle would to be able to get back into doing marathons.
That's right.
I think it's a really good analogy. Is there like advocates in the health system that help people navigate it if they don't have family support or someone to help them?
Yeah, so that's where reaching out to organisations such as Headway or the Brain Injury Association could be really useful for people. And we do often point them because they get it. They understand the challenges of managing an injury like this. But yeah, reaching out and finding people who have also been through this. You know, concussion is a common thing, and a lot of people can relate to it when they've been through it. And so there's also now some peer mentoring programs being set up across the country to link people who have had experience of injury with people who are just going through it. So things like that can be really helpful. But yeah, I would really encourage people to be brave and reach out for help, because a lot of people, you'll be surprised actually, you know, whenever I'm out there talking in the public, the people that come up to me and share their own story. But sometimes we just have to knock on the door for people to answer it and say, yeah, I hear you, I'm with you, I get it.
And I can definitely imagine if people have confusion or trouble thinking through things after a brain injury, it must be very difficult to fill in forms or really understand what the doctor's saying.
Completely. And there's some lovely quotes we got from our qualitative research where people are like, I didn't know what questions I needed to ask. in the appointment. So they couldn't
Yeah.
actually get the information they needed until they realized that they needed to ask those questions. So yeah, it's a really challenging system for people who are struggling with the cognitive impact of this, and even understanding what's happened to them, and that these symptoms are related. Sometimes people don't necessarily relate the symptoms to what has happened to them. We heard that quite a lot too. So yeah, not all of the symptoms are necessarily widely recognized.
And I guess that leads into our next question as well about, do different parts of the brain get affected in different ways after a head injury?
Well, this is something that's really fascinated me. And I guess I realized it was never going to be a simple question to answer because of what's happening, because the brain is being shaken and so many areas of the brain are impacted, as well as then what's going on in those kind of more deeper structures. It's really hard to say that a hit to this part of your brain from an object is just affecting this part of your brain. It doesn't work like that. So it's going to be really, really hard for us to unpick actually, the site of injury and then how some people respond to it. And we see so many times that a person can have a very similar injury. Their descriptions can be incredibly similar, but actually, one person can go on to recover really well and the other one really struggles. So yeah, it's not so simple, unfortunately.
But do the symptoms relate to the area of the brain that's been damaged? It may not actually be the area that was directly impacted.
Now we're getting more sensitive neuroimaging, we'll be able to explore that much more because unfortunately at the moment we can't see what's happened inside our brain. So whilst the impact may have been to here, the injury might be over here, but we don't know that until we can see something on a scan. So I'm really excited by the advances in the imaging area, and that's really enable us to see in much more detail what's going on in the brain and the different areas that are affected. We are seeing some areas being affected more than others because of the way the brain stretches, but we need to be doing more work to really kind of be confident that those are the regions that most at risk.
Yeah. Your guidelines that you're releasing, which is very exciting, are they just for mild TBIs or are they for severe?
They are just for mild TBIs. It was an incredibly long and complex process. I can assure you they took a long time to develop and pull together. There was a lot of debate, and there's still so much that we don't know. And as you'll see when the guidelines come out, they're not short. There's so much to them. And so, yeah, we really just had to focus on the mild brain injuries for now because they were just so complex in themselves.
Is there any work at the moment in your network getting the guidelines into schools? I know you mentioned that often people can present first to a school nurse.
Yes, there's a group of researchers, so Simon Waters and Anya over in our sport and rec department. They're leading a program of work, Frank's study, where they're actually going to be launching a new website shortly, and much more information about how we can manage concussion in schools much more effectively. So yeah, there's some really exciting work coming out from that they've been leading to improve things for kids in school.
Will that be something that teachers will be made aware of as well?
I would hope so. They've been doing a lot of co-design with these the recommendations and the pathways that they're making, and so I imagine, yeah, they will be certainly passing the knowledge through their networks. And with the launch, they're really hoping to get people engaged with that. So that's something that we can alert you guys to, so that you can help
Yeah.
profile and let people who are interested come along to that event.
That it sounds like something else to keep our eye on. You guys have got a lot of things going on at the moment. So next question, how much of a delay is a problem? It seems like if you don't get referred to a concussion clinic um, until you've had symptoms for a while. Is that kind of the case?
Yeah, what we're seeing was that, as I mentioned, what was used to happen was that people would go and seek initial help. They might get some initial advice, some warning signs to look out for, and then they were pretty much left to their own devices. And it was only then when they got into a really difficult space, when they were starting to have threats of losing their job or their relationships were falling apart, that people would then reach back and say, look, I really need some help. And so they were in a really difficult situation. That's where we were like, no, we need a proactive system. We need to keep people in until we know they've recovered. And then we need to get people to these specialist services where who need that support to recover. So it's not necessarily a case that, you know, if not better by 3 weeks. We do tend to see most natural recovery happens in the first 2 weeks. After that point, most natural recovery is happening. And so that's when we really try and suggest to people that they should be going back to their GP, and if they haven't recovered, reaching out and possibly getting a referral to a concussion service at that point. So yeah, generally, you know, first few weeks, we see a lot of natural recovery if we give the brain the right environment. And so we need to be doing the right thing in that time. But yeah, if people are left struggling for a long time, we do tend to find that they actually need much more intensive services when they get to a concussion service, because there's a lot more to unpack at that point. So.
Yeah. And if they can't get referred through ACC, is it best to try and get referred to a concussion service through the GP?
So the GP is the way to go. So they can refer you directly to a concussion service. So previously, it used to be a case that a GP would refer you to ACC and then ACC would refer you on. Our work showed that actually most referrals were being approved, and so it was an exercise that actually wasn't cost or time effective. And so ACC actually stopped that a little while ago. And so now your GP can refer you directly to a concussion service if you need it.
So we are now at 8 o'clock. I think people will probably could probably put in questions for a long time, but we'll wrap it up now with one last question. If someone has been living with concussion symptoms for 4 to 5 years, what can still be done to help recovery? Have you seen some key things for those longer term issues?
Yes, and I appreciate a lot of people often get frustrated that a lot of our research is very much at the acute end, and I guess we're working at the acute end to try and stop people getting to that point that they're struggling 4 years later. But there are many people, unfortunately, at that point in their journey. We're learning new things all the time, and so staying in touch with some of the latest knowledge around these injuries is something I really encourage you to do. But also still remembering that the fundamental principles of your brain has been injured, and so we do need to think about the environment that we're giving it. It can be very tempting in the longer term to keep trying to push through, whereas actually we do need to keep on with this balancing act of finding out what we struggle with, making sure that we do a range of the recharging and the demanding activities throughout the day to give our brain those brain breaks, and to really think about think about how that injury is affecting that person, thinking about what your triggering activities, think about what's your level that you can cope with, working within that level. And as I said, just nudging into those symptoms. People often become very worried sometimes also. You know, some people push themselves too hard. Some people are also frightened to nudge into their symptoms. But actually, we find that, you know, if you think about your symptoms on a scale of 1 to 10, if your headache, you start an activity and your headache's at a 4, for example, if your headache nudges up to a 5, you know, that's your brain saying, you know, I'm starting to struggle a little bit here, but that's actually okay. If you get up to, say, like a 7, if there's a 3-point increase, that's where you need to be stopping before you kind of get to that 3-point increase. So it really is, unfortunately, a case of really reflecting on how different activities affect you and monitoring your symptoms and trying to, as I say, nudge into the symptoms just to kind of indicate to your brain, you know, come on, I'm still finding this really hard. You need to fix that road, but not doing too much that your brain just gets exhausted and then it hasn't got enough energy to repair itself. So it really is that difficult balancing act that we need to just enable our brain to do its thing.
And keep doing those nudging activities over and over again because the brain will take time to repair that road. Would that be the right way to describe it?
Yeah, or if you think about it, like we know that if we take up a new hobby, the brain will build new neural pathways. And the more that we practice, so if we've learned, I don't know, to play the flute, as we first start to learn, you know, you're quite cumbersome, it's quite difficult, your brain hasn't got the pathways in place to enable you to coordinate your hands, your mouth, you know, looking at the page on the notes. And so the more you repeat it, the stronger and the more neural pathways you get in your brain. and the stronger that they become. And so if you think of it like that, that actually, you know, by repeating these activities and keep challenging yourself at a level that your brain can cope with, the more it's going to build and repair and strengthen and in some cases build new pathways. So yeah, just hang in there and don't lose hope.
That's a really great concept, and I'm sure a lot of people find that helpful. And we've been having a lot of thank you messages come through the chat just to say thank you for a wonderful talk. So I'll just echo that and say thank you so much. You're obviously a busy person who's got a lot of amazing things going on, and we just really appreciate you taking the time to come and talk to us and give people some really practical information, and hopefully it will make a difference for a lot of people in the way that they're actually managing their own recoveries. So thank you very much.
Thanks, Ray. Appreciate you inviting me along.
So I'm going to close the webinar now, and I just really want to thank everyone for joining us for this amazing event, and it will be available on our website soon. Good night.